Yep, so UKPDS has shown unequivocally that if you take newly diagnosed people with type 2 diabetes and treat their glucose well from the beginning, you get lifelong protection from cardiovascular and microvascular complications. This is what we call a legacy effect, because even after the trial finished, for up to another 24 years, we continue to see benefits. And then the question is, what is causing that? And my view is that we're probably seeing permanent epigenetic modification driven by hyperglycemia in the people who are less well controlled, and you cannot regain that. So the importance is treat early and treat well. Metformin should be foundation therapy for all people with type 2 diabetes. You don't get tachyphylaxis, it reduces glucose without losing efficacy. But in the UKPDS, the glucose lowering was not as great as with sulfonylurea insulin, and yet the macrovascular benefits were substantially larger. And this suggests that there are non-glycemic mechanisms by which metformin is reducing risk. Again, with a legacy effect, the effect seems to be permanent. And I think, again, this is epigenetic modification, probably through pro-inflammatory pathways. But this is to be explored. It's work for future research. Yep, so type 2 diabetes, as UKPDS has shown, is a progressive disease. You get beta cell function loss year on year, which means you need to improve therapies. Metformin has no tachyphylaxis, as I said before, so metformin, if tolerated, and if the EGFR is not too low, can be continued for the lifetime. It's also important that glucose is controlled by adding other therapies when necessary, and that the other risk factors, blood pressure, smoking, lipids, are also controlled. It's a multifactorial disease, but metformin has a major role. So we don't really have data on starting metformin late. So I think there have been suggestions that metformin may reduce the risk of cancer. Trials are going on at the moment. But in terms of the diabetic complications, I think the message is it's never too early to start the metformin, and you should continue it for the patient's lifetime if the EGFR is okay and they can tolerate it. So the short-term trials are event-driven, which was an FDA requirement, essentially as a safety to check that the drugs are not doing harm. And fortunately, we've seen the new glucose-lowering agents do not cause harm, and in fact, they have unexpected benefits. But the trials are too short to see the true long-term impact, and we need long-term trials or follow the patients long-term after the trial's finished with linkage studies so that we can see if there are any unexpected benefits or risks that come from that treatment. But longer trials are better if we could afford them. If you've only got short-term follow-up, you have very little data to decide which patients will do best in the long term. So following patients for longer allows you to be more certain about who are the responders, who really gets the benefits. And for some patients, some of the drugs may not work. And that means if you could select them beforehand, you could choose which patients get the drug and save money by not giving them to people who are non-responders. So for diabetes management, we need a more joined up management, because therapeutic inertia means people do not get drugs as quickly as they should. It's a multifactorial disease. It's quite complicated for the family practitioner, and so we need more help with apps and software and continuous glucose monitoring to allow us to better monitor and upgrade the treatments. And what we really need about new developments is a drug that either stops the loss of beta cell function or actually restores beta cell function. That would be transformative.